Patricia, are you able to?
Yep, I'll start right now. Good morning, everyone. Go ahead and get started. Oh, 1 second. Can everyone see my screen?
Yes.
Perfect. Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of 1 AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all of its sponsored educational events. In accordance with the ACCME standards for integrity and independence in accreditation education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculty, and any other individual in a position to control content of this activity. Those who have disclosed a relationship with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with ACCME standards. Planners, faculty, and any other individuals in control of content not listed have indicated that they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, Neuro-U. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of next week, participants will receive an email notification of enrollment to claim credit. This notification email will also include the instructions on screen for your convenience. For any issues or questions regarding claiming credit, please contact education@aans.org. Now, to get us started, I'm going to introduce Dr. Hajipanias.
Thank you very much, Patricia. So good morning, good afternoon, and good evening. On behalf of the AANS CNS tumor section, I am so excited to have this webinar today that we're about to hear from a really innovative group that I've gotten to know recently that is almost trailblazing a new area in neurosurgery that we are going to hear about today. Dr. Maria Nur-Olhuda will help us introduce these two individuals. But I want to thank Professor Antonio Dieva and Eric Suero for joining us this morning. All these webinars are on our tumor section website. If you can't make it today, they will be there, and you can watch the webinars at your leisure. I want to thank AANS again for all their help with our webinars. So I'm going to pass it over to Dr. Nur-Olhuda for the official introductions. Thank you very much.
Thank you very much. So it's an honor for me to introduce all these worthy speakers and organizers. It's my honor to introduce Dr. Antonio Dieva, and he's joining us from Sydney. He's a professor and a consultant neurosurgeon and professor and a professor of neurosurgery at Macquarie University in Sydney, Australia. He specializes in skill-based and minimally invasive brain and spine surgery and directs the Macquarie's Computational Neurosurgery Lab, which pioneers AI and advanced imaging research. So it's an honor to welcome him today as he inaugurates this series on computational neurosurgery in neurosurgical oncology. So he has penned down about 200 and more papers, as well as 2 books in neurosurgery, and every one of us who is especially interested in computational neurosurgery knows him quite well. So it's an honor to welcome Dr. Antonio Dieva from Sydney. Thank you very much, sir, for joining us today.
Thank you so much for the kind introduction and for the invitation. So I will share my slide now, and you should be able to see it. Let me know otherwise.
Yes.
So I'm talking about computational neurosurgery, which is a novel field. So I believe that it requires some explanation. Let's start to talk about the what it is, why, and how we do that. So the first definition is an old definition I gave a few years ago. It's a work in progress. It might change over the next years. But so far, we define computational neurosurgery is a novel translational field where computational modeling and artificial intelligence are used to improve diagnosis, treatment, and the prognosis of patients affected by diseases of neurosurgical relevance. Let's check and let's give a look to the neurosurgical evolution. This is the first depiction in a Middle Age book in which we can see a craniotomy. So we had to wait 600 years before we reach the modern neurosurgery with the microscope and all the advancement we're using every day. So the question is, what's next? And of course, people, they think that the next step is robotic neurosurgery, in which the robot is replacing neurosurgeons. But let's be honest, although many people, they think that this is what computational neurosurgery is, that's not the reality. I would like to avoid all the kind of science fiction and the dystopian interpretation of AI. For me, my interpretation of computational neurosurgery is the interpretation of patterns and how patterns can be used in neurosurgery. So for example, let's give a look to the first depiction of a human brain. This comes from a picture drawn in the 1345 in Italy. You can see some very rough definition of the ventricles. But what is important here is that the sulci and gyri are patternless. And we have to wait more than 500 years before Rolando told that there is always a central sulcus there, and the Silvius told about the Sylvian fissure. And there are more and more patterns that nowadays we recognize. But of course, we know that it's much more complex than that. It's not just a sulci and gyri. Nowadays, we know connectomics and we know the structure of the brain. And as human beings, scientists, and the neurosurgeon, we are trained to recognize things. So as a neurosurgeon, we are extremely good to recognize what normal is. This is the vascular of the brain. And we are extremely quick and fast to recognize if there is a pathology, like a tangle vessel, like an arteriovenous malformation. And this is a pattern recognition. It's exactly the same when you see two trees. You recognize that they are trees. You recognize they are different. It's not really necessary to understand that this is a weeping willow and this is a Mediterranean pine. You know that they are different structures. And why? Because eventually there is a morphostructural fingerprinting. And the fingerprinting is telling you something about the name of that structure itself. So let's talk about quantification and characterization of a pattern. How we measure a pattern. Surely we can use reductionistic approaches like Euclidean geometry. We can use a ruler to measure a cloud. But let's be honest, this is a kind of an idealistic approach, pretty reductionistic, and is not really gives the complexity of the natural object itself. So let's go back to a question I had already when I was training in neurosurgery. I was extremely interested in pituitary surgery from the beginning, and also in the research of angiogenesis and the microvascularization. Here we have two slides of a pituitary gland and a pituitary tumor. I used the immunostaining with the CD34 against the endothelium of the vessels. I created some macrovascular catalog, and you can see very, very quickly that in terms of quantity and quality, a gland is more vascularized than a tumor. But how could we measure in an objective way is a different story, because at that time there were not very strong objective parameters. So I found the answer in this very strong sentence from the Singularities in Here book from Ray Kurzweil. He wrote that the brain does not follow a typical top-down design, rather a probabilistic fractal type of organization to create processes that are not fully predictable. So in this sentence, there are all the keywords of most likely of a computational surgery. Pattern, fully predictable, top-down design, and a fractal. So fractal geometry was introduced by Benoit Mandelbrot, who was talking about the complexity of natural objects and the necessity to have to introduce a new mathematical to describe them. So going back to my question, I simply used what Mandelbrot used for other applications. So even the quantification of the geometrical complexity of the coastline of Great Britain, for example. I used that algorithm called local box counting dimension, and basically I deployed this model on the microvasculature, and I found a number, which is the fractal dimension, telling me in one single parameter the complexity of these vessels. So finally, I was able to show that basically the gland is, yes, more vascularized than the tumor, but it's also because there is a completely different geometrical complexity, which is disarranged in the pituitary neoplastic transformation. So here we talk about the pattern, and pattern analysis is also a branch of machine learning that focuses on the recognition of patterns and the regularities in data. Let's talk about another thing that we love in neurosurgery and medicine in general. As doctors, we really love decision trees. So we have some inputs, and according to that, we output a decision making. This is just one of the examples I drew in the handbook of scalpel surgery, or how we do decision making for a large vestibuloadenoma grade 3 and 4 according to the cost classification systems. I was trying to understand if machine learning can help in this. And indeed, in machine learning, there are decision tree learning methodologies, which are supervised learning techniques to build a predictive model on a set of observation. By merging these two, the cognitive flow and the computational flow, eventually we can have something which is a kind of augmented intelligence. And we'll talk about that later on. So let's try to apply these concepts of pattern analysis and artificial intelligence in computational neuro-oncology. We know well that we have two domains on which we work every day, the neuroimaging domain and the pathology domain. In this domain, we can go towards the computational neuroimaging domain, and the other one is the computational neuropathology. So another example, I use the immunostaining for the vessels of a glioma. I want to understand if the computer was able to characterize the patterns in order to recognize different grades of tumors. So I built this model in which the fractal dimension and the other parameters were giving rise to this kind of order from the low complexity to the high complexity of the microangiographic architecture of a glioma. And not by chance, retrospectively, when I asked to pathologists what they thought about this classification, not by chance, these were grade 2, 3, and 4 glioma. Of course, here is an old paper before the 2016 classification system, but this is just to show that morphostructurally, there are some patterns that the computer is able to recognize, and as a human, we can consider this a pattern useful for clinical applications. So by pushing the boundary of this project, we applied the same models also to other kind of questions. For example, how can we quantify the SWI patterns on ultra-high field magnetic resonance imaging? This is a 7 Tesla MRI. I deployed the same algorithm, and finally we have a model in which we could characterize if a glioblastoma undergoing angiogenic treatment with Avastin, for example, it was responding or not to the treatment. So this patient was a non-responder. Every 2 weeks, the vessels were not pruning at all, but they were increasing in terms of macrovascularization, for example. And the same biomarker could be used also for typing, like I did in digital pathology. We did also neuroimaging. And in this characterization of the SWI pattern by means of the fractal model, we saw that these ones having low complexity of the SWI pattern were grade 2 and 3 and 4. And the same, not just for the same type of the tumor with the different grades, but even for different, completely different types of tumors. So this was an automatic classification of lymphoma versus glioblastoma versus metastasis versus other diseases. So basically, the concept is that there is a mathematical model which can be used as a kind of a Rosetta Stone to try to characterize the angiographic architecture or whatever other kind of a feature and whatever kind of a pattern from the structural point of view, but not just there, even from the time series point of view. So we have chronological patterns, how data change over time, or how time series evolve. And this could be intracranial pressure, could be EEG, could be magnetic encephalography, and so on. So basically, fractal geometry, which is a computational model, could be used for characterization of patterns. Now we are already talking about something else, which is reaching the topic of artificial intelligence. It's an old story, started already in the 50s, in which they were trying to build intelligent machines that mimic human cognitive functions. Of course, you well know that there have been a lot of winter and springs of AI, and most likely because I think that there was too much emphasis on the word intelligence, when many of these models were not intelligent at all. Said that, machine learning came later on with algorithms able to learn without being programmed. And after that, there was the explosion after 2010 of the deep learning, in which machine learners were able to learn using multi-layer neural networks. This brought to the revolution of the actual generative AI, in which we can generate images, text by means of a large language model. And this last phase of AI has created really a huge and the Florida spring of AI in all the fields, as you well know. And now we are already approaching the next future in which we have agentic AI going towards artificial general intelligence, which is the future. So let's do an exemplary computer vision-based workflow in brain tumors. We know that we have the imaging part, the digital pathology part. Let's start from the imaging part. You know well that since 2012, there is the BRATS challenge, in which there is a kind of a consensus of experts drawing the segmentation of brain tumors, the solid part, the necrotic part, for example, and the edema. And this ground truth is compared to the best model predicting the same segmentation. So this is our contribution. We've done other contributions, but every year there is a winner of this competition. But why is it so important to have an automatic recognition of the segmented brain tumors? Is not only for volumetric analysis, which is anyways paramount, but it's also because we can deploy other things on this region of interest. For example, radiomics. We can do a quantitative analysis at the voxel level of many morphometric features. Now, these features are measured at the voxel level for each single slice, for each single MRI, multiplied or multiple patients in longitudinal fashion. They give rise to millions and millions of data points. And that's why machine learning is so important, to reduce the dimensionality of this data set and to try to infer some features or some outputs. This could be differential diagnosis or even a prognostication, for example. We can, this is the pipeline that we built up many years ago, and nowadays is much more developed than this. But just to give you an overarching idea that every brain tumor coming to my clinic nowadays, there is the pre-processing, there is the automatic segmentation, there is the manual segmentation. We go towards the radiomics and the many deep learning models in order to deploy some output, which could be in terms of a differential diagnosis, for example. We can push the boundaries even towards the prediction of a genetic status. So this is the most recent systematic review and the meta-analysis we published. And for example, we try to understand if deep learning can be used to predict the genetic status simply on the preoperative MRI. So on the IDH prediction, the sensitivity nowadays is 80% and 85% is the specificity on a pooled analysis. For 1p19q is slightly lower. And we found a lot of heterogeneity driven by different segmentation tools and the deep learning integration. But now the point is that these numbers are extremely promising, and these numbers are much better than the previous years, but most likely are much lower than the future, which means that most likely in the future we are going towards a very close to the gold standard prediction of the genetic mutations in brain tumors just by looking at MRI or other imaging modalities. We can do the same also in the pathology realm. Remember that nowadays a pathologist is extracting features in order to try to depict patterns, and by using a lot of laboratory technologies is able to give us what is considered the gold standard, the final diagnosis, which can be integrated or not. But let's do the same by using some technologies similar to the ones that we use in neuroimaging. Instead of talking about radiomics, now we can talk about pathomics. So we digitalize the specimen, we can deploy many analysis, morphometric analysis at the pixel levels, and by doing that, we have a huge data set that can be analyzed by means of deep learning and machine learning to have automatic classification or from typing and subtyping point of view. But this could be done also in terms of genetic prediction. So before I showed you the radiogenomics results, look at this data now, for example. We have many gliomas with staining H and E. Every pathologist in the world might tell you that these are all gliomas, but no one of them might tell you what's the IDH mutation status, simply because there is no feature there telling you this information. So you need immunohistochemistry and genetic sequencing. So we had the idea to see if there is something hiding here that the machine is able to see. And we trained a ResNet 50 architecture in deep learning. We did the training data set, and on the validation and the testing, we got a very high prediction of the IDH mutation status. It was 85%, which is incredibly high, but still very far from the gold standard of 1% told by the pathologist. So we try to understand by means of a root cause analysis what could be the problem. And as you know, in machine learning, many times the problem is related to the size of the data set. So you know that Google is extremely good to recognize cats and dogs because it's been trained on millions and millions of images. But in glioma, many times we have just a few hundreds. In this case, we had 900 cases. So we tried to synthesize more glioma in order to increase the size of the training data set and in order to increase the accuracy. So we used a generative adversarial network model for augmentation. Nowadays, this is a state of the art. Everyone knows what the GAN is, but this was in 2019. It was one of the first applications in digital neuropathology. And this is how the algorithm works. Basically, by using the GAN, we were synthesizing a new glioma. And when we reached the number of 3,000 gliomas, which means 2,000 were completely synthetic, the accuracy of the IDH prediction task skyrocketed to 95%. Nowadays, we are using also other models, including transformers, and we are reaching almost 90-80%, which means that most likely in the next future, we'll never get rid of the pathologists, for example, but most likely we'll be able to replace the actual techniques in terms of genetic sequencing or immunohistochemistry. And this will save a lot of time, but even money, because it will be cheaper and faster. What about the prognostications? Well, we reviewed also this aspect. Is an MRI able to tell you the prognosis of a patient by using features extractions and the deep learning? Well, we are not there at all. The accuracy nowadays is between 60 and 75%. But now let's hypothesize that this number is increasing year by year, and that one day will reach 95% or even 100% accuracy in prediction of the prognosis of a patient. How could you tell this information to the patient and to the family of the patient himself? Or consider all the implications from the legal point of view, the insurance, how could you use this information? So this means that there are so many ethical implications that we have to consider that we decided to sit together a kind of task force and to try to draft the declaration of the ethical principles of a computational neurosurgery. So these are the principles neurosurgeons should abide to in order to deploy AI models in an ethical fashion. So this was a chapter with many authors published in the Computational Neurosurgery textbook, but this is a work in progress. And indeed, we are going towards what will be next year, the Declaration of Sydney, in which a task force will be joined by other people, including ethicists, philosophers, lawyers, policymakers, and we try to make this kind of a declaration, which will be something that we can create some safeguards for the computational neurosurgery of the future. So to summarize, AI in neuro-oncology is mainly based on computer vision when we talk about the neuroimaging and neuropathology. So it can be used in pre, intra, and the postoperative neuroimaging, and we talk about radiomics. Imagine that you think that even connectomics uses a lot of machine learning for the advanced imaging we use for the connectomics itself. Can be used for digital pathology in the intra and the postoperative imaging by means of pathomics. But remember that pathomics is just one of the many omics that we can do on brain tumors. There are many multi-omics approaches nowadays, like genomics, transcriptomics, metabolomics, proteomics. And all these omics give rise to a huge data set, really, really huge. And that's why we need, again, machine learning to reduce all this data set to something which is much easier to be inferred and used not just for research applications, but for the benefit of our patients and to understand brain tumors better. Of course, computational neurosurgery entails many things more, including robotics and preoperative planning, but I was trying just to stick more to the computer vision part of neuro-oncology. The last part I want to talk about is the decision making. Remember that the doctors of the past was alone. So basically, they were using their own skills, their own semiotics more than imaging, and very, very rudimentary tools in order to have a diagnosis and to propose a decision making. Nowadays, the workhorse of the concept of modern medicine is the MDT. So we sit together and we try to have the best decision making. So what about AI? So let's be honest. As a neurosurgeon, it's very, very rare that I bring a patient to theater without asking to the MDT. So this passes through the radiologist, and there might be error in the radiological interpretation, or there might be error in the decision of the MDT. So there are still some constraints, limitations. MDT is very good, but it's not perfect yet. And we tried to summarize all the pros and cons in this review, for example. But imagine that we can bring AI at the table with us. So AI is sitting at the MDT with us, and this is just because it can reduce the complexity of the data coming from patients in longitudinal fashion. It can help to summarize information, and it can help every one of us to improve the decision making. So this is the AI which will not replace any one of us, or will never replace the MDT itself, but will augment the decision making of the MDT itself. And that's what the AI, in my interpretation, which is the augmented intelligence rather than artificial intelligence, which is a pretty common concept nowadays. But I published this more than 6 years ago in the Lancet. And it was the proposal of the AI augmented MDT, which was considered a hype or a hope, but most likely this will be the reality of the next few years. How we do that? Well, we have to understand the basics. The foundations of AI are maths and computer science. So we don't want to be only simple end user, because otherwise we take it in a very passive way and we do not understand the pros and cons. So we have to try to understand as much as possible. But it's also true that the complexity here could be overcoming really the expertise we have, or even the time we can dedicate to this new field. And that's why we need the convergence of many, many disciplines. Neurosurgery is just ancillary to the computational neurosurgery, along with all the clinical neurosciences, for example, neuropathology and neuroradiology, the cognitive neurosciences, computer science, mathematics and stats, epidemiology, engineering. And that's also the reason why I founded this lab, the Computational Neurosurgery Lab, 7 years ago, exactly to put together all these people under the same umbrella to discuss neurosurgery. And it is also the reason why I founded the Computational Neurosurgery Fellowship. We do subspecialty with the fellowship. Of course, there will be never a Computational Neurosurgery Fellowship as a discipline in the future. But it's important that neurosurgeons learn the foundations and they can deploy these new technologies to their own disease that they are expert about. So it's a time to learn AI, don't fear it. There is nothing really that we should consider from the dystopian point of view for the erasing of the mankind. These are other considerations that they go out of computational neurosurgery, because we are using it as a smart tool to make things better. So it's time to use AI in a proper way in the computational neurosurgery field. And we talk about all these more and more in February at the first World Conference of Computational Neurosurgery in Sydney. I really hope to see you all there. Thank you so much, and I will pass the talk to the next speaker, to Eric.
Thank you very much, sir, for this amazing talk, and it was very insightful. I hope we will be able to take more questions by the end of our webinar. So I would like to introduce Dr. Eric Soero Molina. He's from Germany. He's basically from the University Hospital Münster, and in computational neurosurgery fellow right now at the Macquarie University at Sydney. His work focuses on minimally invasive skull-based surgery and cutting-edge optical imaging from brain tumors. So it's an honor to welcome him to deliver a talk on case applications, AI-supported modeling in preoperative and intraoperative imaging. Thank you very much, Dr. Molina. The floor is all yours now.
Thank you very much for the kind introduction and the invitation. It's great to be part of this new series. So after a great introduction from Professor Dieva, taking us through some of the foundations of this field, we wanted to bring you some case applications based on some of the projects we have been recently doing. And I'm going to focus on preoperative imaging, specifically on 2 projects we recently published. And if we have time, talk a little bit about intraoperative imaging and hyperspectral imaging, which is something my group has been quite active over the past years. But for the sake of time, I think I'm going to focus on the first 2 projects. So 5-ALA, it's of course now workhorse in glioma surgery, and it was officially approved for high-grade gliomas, or what we understood under high-grade gliomas back then in 2006, at least when it started in Europe. But we also have this low-grade or now lower-grade gliomas, where the question is how useful fluorescence is there and what is the incidence. And the way we use this sort of technique in these tumors is different. So in high-grade gliomas, we want to maximize resection, and lower-grade gliomas, we really want to find anaplastic focus to avoid undergrading these tumors, because we know, especially when we use amino acid PETs, that some regions of these tumors can be of higher malignancy, and fluorescence help us find those regions, as we have demonstrated in different publications. So we know that around 20-30% of these tumors will fluoresce. It's very challenging to predict which, but almost half of these tumors will actually have an anaplastic focus. So you want to take that tissue and send it to pathology deliberately so you don't undergrade them. So we have done studies to try to understand timing of the fluorescence kinetic, but also which factors influence if a tumor that, at least on the MRI, appears lower grade, will actually fluoresce during surgery. So we know that contrast enhancements with gadolinium in the MRI will kind of predict this, but also the FET PET SUV max value, the absolute value also. Also things like ADC, which is an indirect marker for cellularity, will kind of predict this. And we have been playing a little bit also with the dose of application. We had the underlying hypothesis that 5-ALA administration and actually uptake in this tumor has a lot to do with permeability and the blood-brain barrier. And just the idea was that by increasing the amount of 5-ALA in bloodstream, the chances and probability of 5-ALA going through the blood-brain barrier being uptake by the tumor will be higher in this sort of semi-permeable situation. Different in the high grade, where you have this bulk movement, it doesn't really matter if you give more or less. The limitation here is the tumor actually that metabolizes this 5-ALA. So we actually saw that almost 90% increase in this small study of intraoperative fluorescence could be demonstrated, which is promising also for future trials. So this is a very old slide, but it's still very relevant because it's still very true. So when you have lower grade apparent tumors, then any form of contrast enhancement will predict fluorescence, older patients, bigger tumors, but also the FET PET uptake ratio, which is something we measure, will also predict fluorescence. So in this situation, it really makes sense to use 5-ALA to find these regions of interest. So the question we had was, can we actually use MRI in AI algorithms, this topic of our webinar, to predict intraoperative fluorescence? So we searched for our database, all tumors with, let's say, lower grade radiographic characteristic, meaning no necrosis, no irregular ring enhancement, and search for which of these patients actually received 5-ALA, and also which of these patients had an information in the surgical report if the tumor was fluorescent or not. One of the limitations, I think, is this is an old cohort part of it, so a lot of these tumors were graded after the 2016 classification, but still on the MRI was exactly those tumors where we don't really know if they're of low or high grade. So we had this computational task that we wanted to do. We wanted to predict intraoperative fluorescence. In the second part, I'm going to talk about synthetic FET PET generation. So this is a common pipeline of how to do image analysis, either with machine or deep learning models. So the first you do is an image acquisition. Then this data, which is often coming from different MRIs, needs to be standardized and put all together. I'm going to talk a little bit more in detail about this in a while. Then you need to select a network architecture. And then you have a very important step, which is the cross-validation. And basically, you split your data into training, validation, and testing. And this model undergoes iterative training. You can use hyperparameters to fine-tune your model and then and validate it to reduce what we call overfitting. And a very important step is the external validation to provide, let's say, the generalizability. You can, test your model in independent data sets from other scanners or from other clinics, for instance. And then the selection of evaluation metrics is also very important to present your results. So the pre-processing pipeline, kind of like I said, standardize your data. So we know that MRI images often suffer from intensity inhomogeneities, what we call bias field, which can really negatively affect your analysis. So these inhomogeneities can result from scanner imperfections or acquisition artifacts, even pacing positioning sometimes. But bias field corrections, they normalize intensity variations, and they assure more of, like an accurate representation of all the anatomical structures. Then we have what we call interpolation to isotropic resolution, which actually ensures that voxels have equal dimensions in all directions. Then you co-register all the images, you map to a standard template. We normally use Montreal Neurological Institute template. Kind of everything has the same orientation and dimensions, and then you do skull stripping to remove the skull and then just stay with the most important brain part, what you want to do for your analysis. So we chose this unit architecture, which is a pre-trained variational autoencoder. It has this encoder-decoder convolutional neural network that was really tailored specifically for brain tumors segmentation. And Professor Dieva talked about the BRAD challenge that we actually adapted this pre-trained model for one of the winning algorithms. This is the nice thing about this model, so you can use and adapt and reuse it for your own research. So the way it works is that this model kind of like breaks down the image into very essential information. This is what we call here the bottleneck layer. And this information can be used, of course, in this case, to segment the tumor, but we can also use it to extract features and do classifications on it. Dimensionality reduction has already been mentioned, but just as a small explanation, basically we have, especially in image analysis, very, very complex, high-dimensional data set, and we can use tools like principal component analysis to kind of break down the dimensionality and lower down here, as an example, from 3 to 2 dimensions. But you see also one of the limitations is that these techniques have the underlying assumption that the data has a linear manifold. So non-linearity, a little bit of non-linearity can be lost here, but still it's a very, very powerful tool to kind of like simplify the information that we do it and then apply, for instance, with different machine learning classifiers. So this is the whole pipeline. We had the images, we did our pre-processing, we extracted the features and did dimensionality reduction. And with this information, we added a out-of-the-shelf random forest. It's a machine learning classifier, and try to do the prediction. And the results were pretty good. We could predict intraoperative fluorescence with 80%. And you have to think about it, this is just based on the MRI. So we can still make this model more complex, adding things like age, tumor size, FET values to improve it. But it was really nice to see that only based off the MRI in these 3 sequences, we had a very good prediction. This is published in Neuro-oncology, Journal of Neuro-oncology, if you want to take a look. The second project we want to talk about is synthetic FET PET regeneration. And I know in the US this is still not approved, but I think it's coming. But we have been using FET PET since I ever remember, so for a long time now, because it's really now become essential in glioma treatment. It really identifies malignant subregions. It monitors treatment response. It really helps in distinguishing sometimes recurrence, pseudoprogression, radiation necrosis, all those things. It's been endorsed by different organizations like the ANO. The RANO has an own working group working on PET, writing great guidelines. And it's really useful throughout all glioma treatment in both higher and lower grade glioma. And now we have been seeing a lot of advance in imaging analysis with deep learning, especially the image-to-image translation and restoration. And the GANs, the adversarial networks, which we were talking about, has been helping a lot in all of this in all these cases. And especially in nuclear medicine, we're seeing image denoising, attenuation correction, which is very important. Also image reconstruction with the help of these models. And already in different fields, we are seeing image-to-image translation out of X-ray, making MRIs or CTs, or out of MRIs, making CTs, and all this, image translations, it's kind of like exploding over the past years, which is very, very promising. So we wanted to know, can we actually create a synthetic PET based off the MRI? And the goal of this message was not to replace nuclear medicine or PET as such, but to provide models for those regions in the world that don't have access to this technology and might be helpful to have them. And you see some of the examples, how here, for instance, a CT is being created with different iterations, getting better, better, and better, and you have always the ground truth to compare it. So we look again at our cohort, the same project. We had 225 patients with preoperative PET. This was not as well balanced as the first project. The first project was quite well balanced, but because of course, these are all surgically treated patients. So most of them had a hotspot. And we used these 3 sequences and the attenuated, corrected 20 to 40 minute post-injection PET sequence. So we had this MRI for different sequence, and we had this so-called split infusion model for processing all of these different sequence. We had feature extraction, then concatenation, which is just a fancy computational word for joining them all together, and a self-attention mechanisms. So this is all achieved through a convolutional process that kind of like filters the image data and isolates really essential elements from each sequence and put them all together. And this last step, the so-called self-attention mechanism, they apply to kind of like refine this mix of information, and it actually selectively selects features that are essential for the PET generation. Another point is that MRI data is kind of like three-dimensional. We actually converted into 2D because 3D convolutional neural network are very, very computational heavy. But 2D slices are easier to make calculations at, but of course with the limitation that they may miss cross-slice information. So this is the architecture of the GAN model we use. This is a so-called pix-to-pix model, which was adapted from a Polish one. It's a conditional adversarial network that's used for image translation. So we have a generator that processes all these inputs I was talking about and produces a synthetic PET image, which along the authentic PET image kind of like evaluate them on a patch level. This is the patch GAN discriminator for really authenticity. So this whole network aims to kind of like fine tune both the generator and discriminator in a kind of like a competitive setup. So the discriminator assesses if the generated PET patches are real or fake, contributing to what we call the discriminator loss. And at the same time, the generator is trained to minimize the generator loss by producing images that really closely resemble authentic PET images. And this is an iterative process that goes over and over again until we have a really, really good image. And this is the results. You can see here the row of the synthetic PET, which is really, really, really good and resembles some of the original PETs. Only in this case, this is one of the examples, on a few examples where it didn't work well, when a very small uptake region here was not well replaced. But this is actually the first time we're demonstrating that this is feasible and possible in the neurosurgical setting in gliomas with FET PET. And we also showed all of these synthetic images to nuclear medicine radiologists, and they found them useful in 85% of the cases. Also, the overall comparison with some evaluation metrics showed overall a very high benchmarking, a very high correlation, which was very good. So the thing is, we just don't look at the images when you do FET PET. We look at evaluations of the uptake of FET. So the problem is that with pre-processing, all of this voxel-based information is lost. So we cannot perform neither static or dynamic FET analysis. So what we did, we trained parallel, just a very simple model to see, based on the information we had, also based on the MRI, to see if this is a hotspot or not. So this is a little bit different than the pipeline I showed at the beginning with the deep learning architecture. So this is more of a radiomics-based analysis where you segment the tumor and then you have this man-made features that you can extract. You can also do classical statistic on this. This is not equals AI research, but in this case, we use a feature selection, which is also a sort of dimensionality reduction, and then use a random forest classifier. And so we could predict with 80% quite well if this is a hotspot or not. So the idea was in this first project to have this kind of like pipeline on two sides. The first side, create a synthetic PET, and on the other side, have that information, is this real a hotspot or not. And I think future work will now focus on trying to also try to get a prediction also of the FET uptake, and so we can really do nice static or even dynamic analysis also for future projects. So this has been published in Neuro-oncology Advances, if you want to take a look. And I think for the second time, I'm going to stop here and looking forward to the discussion. Thank you very much.
Hey, great talks, both by Antonio and Eric. I had a question here, and I think we're heading into this era where we're going to have instantaneous information that's provided to us by our imaging, our pathology, even, Eric, in your case, fluorescence, intensity, um, those types of data points. And I'm wondering, are we going to be in a situation where all this information will be provided in the operating room to us? Are we there yet? I mean, how far are we there? How far are we from that point where in the operating room we can make these predictions, go to the waiting area of our patients, and give them this information that we would feel confident with? Are we close to that, or do we still need some time to really understand the accuracy, the sensitivity of these types of data sets that you all have presented this morning?
It's a good question, Costa. I always like to mention Professor Yazergil saying the more you know, the more you see. And in this case, it's really the more you know, the better you can treat your patient. So I believe that on one hand, we have a huge data set which can be confounded sometimes. But on the other hand, this data set can really improve your differential diagnosis and decision making. So to answer your question, I believe that many of these things are research tools which can be used in the pre and the post-operative assessment. But it's true that many of these are already implemented in the surgical applications. Because for example, if we have a 98% prediction on a simple frozen section during surgery that there is a mutation or not, and we can know these in real time rather than waiting for immunohistochemistry genetic sequencing, eventually we might tailor the resection in a different way. So, of course, there are questions how you tailor the resection if you already know if there is a mutation or not. But, and we can discuss about that. But what I'm telling you is that if we have more predictive power and more gold standard, which comes even before the operation or during the operation, in a time which is extremely sensible, because at the end of the day, we are just relying on what's happening in real time. But if that real time can be improved, augmented by kind of assistant, which in the future eventually will be agentic, eventually in the future we have something really in the theater, which is giving you in real time potential decision trees. When I put the slide of the decision tree. So maybe sometimes you do something which is you think is right, but retrospectively you consider that maybe it was wrong. And could have been better if you had an expert with you? Yes, most likely yes. Could have been better if that expert was an agent, was an artificial agent. So what we are going to now is trying to transform these tools in something which really can be deployed in surgical theater, in the clinic before surgery, and in the lab for as a research tool. So the answer is a yes or not. Yes, in the future, we are not there, in my perspective, but we are getting there. Would you like to add anything, Eric?
No, no, I completely agree. I mean, I think it always depends what exactly are we talking about, what kind of technology, what kind of information. We have been seeing, for instance, the groups are focusing on Raman spectroscopy that have been really forcing to use a lot of this technology already during surgery, doing biopsies during surgery and guiding maybe EMR resection. This is a good example of how these technologies are being translated. We're trying to focus more on the actual intraoperative imaging directly on the tumors and are kind of like dependent on the quality of the hardware and cameras we kind of receive from the industry. So sometimes it's also the speed of the images that we can acquire, the processing. So this is all a development, but I think we all have to try to already from the beginning develop our models and try to understand what is it that we want to know and in what way. So when we have the appropriate hardware at the appropriate speed, we're able to apply any of these things.
And this has also logistic and economic implications. Imagine that you want to do a fat PET because it's extremely important, but you don't have it, but you have only an MRI. So let's generate a PET scan which can make a decision to make it better. Or imagine that you want to use 5-LA in that patient and you predict with a very high accuracy that that patient will not have a fluorescent tumor. Well, if the prediction is very high, maybe you can avoid to give 5-LA. You save also some money. So I think that there are all these kind of practical implications that are really beautiful research tool nowadays will become really applied very, very soon in theater and in the hospitals in general.
Sir, there is also the concept of a digital twin. Sometimes, we discuss the concept of creating your digital twin in which you actually make a model of your patient, and that's how they guide. They say that it's very helpful to guide you in tumor resection and etc. So, is there a concept that can be applied like intraoperatively, like Professor Costas has very nicely mentioned? I've seen that people are using a lot of augmented reality intraoperatively, especially in some centers in Russia, where they have quite a lot of application of augmented reality. Somehow, can we apply this type of can we merge the concept of a digital twin with intraoperative augmented reality?
That's a very good point. We did not mention the digital twin, and actually it's a very good point that we are trying to work in the future, because imagine that every time we do a decision is very, very binary. We do 0 or 1 and we don't back anymore. And if we don't go back and there was a complication, that's it. Imagine that we can simulate all the potential options when we have a decision tree on something which is digital. And by doing that, we reach the best outcome for that patient. When we have done all the simulation on the digital twin, which can be in terms of surgery, in terms of chemotherapy, radiation treatment, multimodal treatment, immunotherapy, whatever we want to deploy in that patient, and we can simulating the best outcome, eventually this will bring us towards a better decision making. We have one patient, but eventually we have many, many digital twins of that patient. And that's where could be the next horizon in this landscape.
Yeah, I think there's really a huge opportunity also for surgical training, if you think about it, and especially microscopic, endoscopic kind of like area when you can safely simulate a lot of these scenarios. I think that's going to be very good.
Maria, we have a question here. Actually, it's from one of our research fellows. Yeah.
Dr. Jeremy, yes, he's saying thank you very much to the speakers for this insightful presentation. When it comes to the ethical implications of integrating AI into neurosurgical practice, how can we effectively address concerns related to patient safety, data privacy, algorithmic bias, and the balance between human judgment and machine-driven recommendations? What strategies do you think are most important to ensure that AI is implemented responsibly in teleclinical care?
Yeah, the juridical, legal, and ethical aspects are endless here. And let's be honest, we have to be pragmatic. We have to get the advice of experts in the field, including ethicists, philosophers, and lawyers. And we have to deploy this in the most ethical fashion. So the privacy is one of the biggest problems we are dealing with, because when we do training data set, we have to be sure that the information or the input have been acquired in an ethical fashion. With the consent of a patient and so on. So there was a kind of a Far West in the past in which basically there was really a kind of a digital anarchy in which there was no control at all. And nowadays this anarchy is we're trying to drive this anarchy towards a very good juridical pathway. Putting some limitation is good. Putting too many limitations might constrain the development of the field. And that's why I was also talking about the Declaration of Computational Neurosurgery. This is an attempt that everyone is doing in every aspect of a healthcare, not just in neurosurgery. And everyone is talking about the ethical deployment of AI in any disciplines, in any field. So to be pragmatic, we want to just try to not reinvent the wheel, but we want to see what the others are doing in other fields and how we can apply in our own field, in neurosurgery. So there will be huge discussion and implications. And all these models, they have to be brought to the patient too. They have to be aware that we are using somehow some techniques which are technological advanced, but eventually might compromise privacy, and we want to avoid that. But this is a continuous work in progress.
Wonderful. Well, I think at this point, Maria, did you have another question, or should we wrap things up?
Thank you very much. No, just a little thing to add. Since we are all of us are using a lot of Chat GPT, and I have seen that it is usually helpful in fetching new papers and making references and like guideline references, etc. But sir, I have seen that obviously it has not been designed for radiomics, but sometimes if you wish to have a comment on radiology, it usually gives you good anatomical data, although it cannot. I've noticed that it does not very well read the radiology, like the MRI scanner, etc. However, I have sensed that sometimes if you correct it, it sometimes gives you a better answer next time. So how do you think that, is there any application of ChatGPT somehow for the young trainees, not for those who have already done this, but for the trainees? Do you think it can be somehow helpful, although it is not dedicated application, and obviously it doesn't read nicely? We know this, so we can very well assess that it's not reading correctly sometimes, most of the time rather.
I have an answer, but I don't want to monopolize. Eric, you want to go ahead?
No, it's
Otherwise,
okay. You can go. It's okay.
yeah, well, large language models are used now in neurosurgery, and we have many applications. This goes from a legal report, for example, to summarize a lot of information. So we have some scribes now putting together the information we are talking to with the patients, and automatically we generate reports. And there are also the multimodal acquisition of data. For example, MRI transformed directly in automatic report. Of course, they're not very good yet. They are pretty good with X-ray of the chest, but the
Yes.
complexity of MRI is too high for an automatic
Yeah.
report. But eventually, yes, a large language model, and not just ChatGPT, there are other tools as well, is the future to implement the field of neurosurgery and to make our job quicker and better eventually.
Maybe just
Yeah.
one last thought to finish. I mean, I think the one thing we have to keep in mind, and this is something we were discussing also over the past day in some of the talks we had for the declaration, is that a lot of these models are quite intelligent and they can reason, but intelligence does not always equal truth. So I think this is one of the main problems. So you create a lot of output that sounds nicely, but you really have to critically assess what is it that you're getting. So if you basically just, transfer knowledge from ChatGPT to other sources without really critically assessing it or
Yeah.
evaluating it, then it's going to be a huge problem. And I think this is also going to be for the next generation to try to kind of like cope with this sort of ground truth, non-truth, some sort of truth. So intelligence is not always equal truth. So this is something you just have to keep in mind.
So human
More
supervision
like
is paramount, of course, and human supervision is from neurosurgeons in our case, in our field.
Excellent.
exactly.
Well, wonderful webinar. Thank you very much for a very insightful set of talks. And we're looking forward to push a new webinar series that will be focused on computational neurosurgery in the future. So stay tuned for that. I wish everyone a great morning, afternoon, and evening, and we will see you soon. Thank you very much.
Thank you so much. Cheers.
Bye.
Bye.
Farewell.